Hi everyone, welcome back to the Med Student Notes. So today I've taken kind of a complex topic and I'm going to try and make it as easy as possible. And we're going to do a flowchart and algorithm, which always helps. So hyponatremia is when our sodium levels fall to less than 135 milliequivalents per liter. So usually when they fall to even less than 115, you'd see stupor, seizures, coma. But around the range of 125, you would see headache, lethargy, confusion. So the clinical features that you see are going to be mostly vague or neurological because once the sodium decreases, there's going to be an osmotic intracellular water shift, right? Which will cause cerebral edema. So, usually neurological issues. So, if this hyponatremia develops in less than 2 days, it's going to be acute. If it takes more than 3 days, it's going to be chronic. For now, let's try to figure out how you find out the cause of hyponatremia and the initial steps of trying to investigate. So, the first thing you want to do when you check the serum and you find hyponatremia, you want to check the plasma osmolality. Now, your plasma osmolality can come out to be less than normal. It can be 275 milliosmoles per liter, or it can be around normal, 275 to 290, or it can be high, more than 290. Now, these values will kind of differ minutely based on different textbooks, but for now, I'm going to use these values, and you can look at whatever reference you're using and go based on that. So, normally, you would think that if sodium decreased, that is, the solute content decreased, your plasma osmolarity should also decrease, right? That would be our normal thinking. But if you see hyponatremia and the plasma volume is the same or it is increased, then you would begin to wonder what happened. So, a case where this can happen is if there is hyperproteinemia or hyperlipidemia. Now, essentially, this is a pseudo hyponatremia because what's happening here is there is no decrease in the sodium itself. But because there's going to be an increase in other solute, the total plasma volume is going to expand. The total volume will expand. And particularly older lab techniques, they're going to measure sodium relative to the plasma volume. So there's no decrease in the sodium itself, but there's an increase in the plasma volume, which is why it reads as hyponatremia, while in reality, that's not the case. So that is one thing. And if the plasma osmolality has increased, then you'd begin to wonder why. Now, in this case, for example, if there's hyperglycemia or you're using mannitol, these increase the plasma osmolality, right? So, what happens is when there is increase in plasma osmolality, water from the cells is going to come here to dilute the plasma, right? Because water is going to flow from lower osmolality to higher osmolality. So when this water comes in, we have our sodium here. When this water comes in, it's going to dilute this volume. So it's going to be a dilutional hyponatremia in this case. So that's about when plasma osmolality seems high. Now let's come back to decreased plasma osmolality. The next thing that you want to do here is you want to check urine osmolality. Why? So now see, in our circulation system, so this is a very crude rudimentary diagram that I made, our heart, and just assume this is the abdominal aorta, the circulation system, the renal arteries coming to the kidneys, all that. If there is dilute fluid here, if there's dilute fluid here, less solute or more liquid component, what the kidneys should do is the kidneys are going to try and send out water right? Because it is dilute here and you want to keep a normal balance, you will want to send out the excess fluid, right? So if the kidneys are functioning normally, that will happen. But if the kidneys are also sending out high solute, if we have dilute fluid, if we have dilute blood, but our urine is concentrated, that would mean that maybe the reason that the blood is dilute in the first place could be because the kidney is sending out all the solute, right? So we essentially want to check if I've kind of simplified this explanation and given you the basics of it. So essentially, we want to check if, perhaps there's something wrong with the kidney. Is that functioning properly? So now we'll see. Now, urine osmolality. If this is less than 100 osmoles per liter, if we have dilute blood and we have dilute urine, that means the kidneys are doing their job. So this dilution in the blood is coming from somewhere else. So when could that happen? If you have polydipsia, if you're drinking a lot of water, you're drinking a lot of normal water with no sodium in it, so your water content is going to increase, your sodium is going to be diluted sodium, which will cause hyponatremia, correct? The other thing that you would see is beer potomania. Now, this is pretty interesting and also is very similar to polydipsia because beer also has very less solute. So, beer has very less solute, and you're taking a large amount of beer. What will happen? You'll have a lot of solvent, you'll have less solute. So, relatively, you have less sodium, hyponatremia. A very important thing to remember here is the kidney cannot just secrete free water. There has to be some amount of solute. So, essentially, what's happening in these cases is we have a lot of fluid we want to let go of, but not enough solute to send out. So, a little bit of solute with little water you'll send out in some urine and you're done. So, you're being left with a lot of fluid in the body that you can't eliminate because you don't have enough solute to eliminate it with. The third thing is post TURP. What is TURP? This is transurethral resection of prostate. Now, what happens here is usually they're going to irrigate the surgical site, and the bladder is highly a vascularized structure. So, the things that we use to irrigate the bladder, if they slip into the circulation, then what will happen? These fluids are going to be hypotonic, so they're going to be dilute again. So, the fluids that we use to irrigate the bladder here will enter the circulation, and again, the same thing. They will dilute the circulation. So, our sodium is going to be here, the fluid content is going to be increased. So, what happens? Dilutional hyponatremia, correct? I hope that was clear. The next thing, if urine osmolality is more than 100 osmoles per liter, we check the ECF, the extracellular fluid volume. So now you'll have three possibilities here. You can either have hypovolemia, less fluid, euvolemia, normal fluid, hypervolemia, a lot of fluid. Now, what you want to do here is, again, in the case of hypovolemia, you want to see how much sodium is being excreted in the urine. Because if we have, the normal amount of sodium excreted in the urine is about 20 milliequivalents. So, if you have hypovolemia, the kidney doesn't want the body to be in a state of hypovolemia, right? It wants to retain some water to get back to its normal fluid status. So to do that, it's going to reabsorb some sodium. So the normal amount of sodium being excreted will be reabsorbed more than that. So the kidney is going to reabsorb some sodium. So when it reabsorbs sodium, aldosterone comes into play here, right? Once sodium is reabsorbed, water is going to follow, and this is a compensatory mechanism to deal with hypovolemia. So if the kidney is secreting less than the normal amount of sodium, that is less than 10 milliequivalents per liter, we're going to say, oh, okay, the kidney is doing a good job compensating. There's nothing wrong with that. So, in what cases would this happen? If there's going to be some fluid loss, and it's not the kidney's fault and the kidney is trying to compensate, this could be because of some vomiting where you're losing fluid, right? Or some remote diuresis, extra renal losses also. So here your kidney is just trying to compensate because there's volume loss from other sources. The next thing, if it's going to be more than 20 milliequivalents per liter or around that value, that means the kidney is not doing anything to compensate. And this could be because of hypoaldosteronism. So here, if there's no aldosterone, there's not going to be sodium absorption properly, right? If there's no sodium absorption, there's not going to be water reabsorption properly. So you're going to be hypovolemic and hyponatremic. You can also see this condition in ketonuria or bicarbonaturria. Essentially, in these cases, these are going to be osmotically active and pull out volume along with them. Pull out volume and sodium into the urine, and that's going to cause your concentrated urine with hyponatremia in the serum. So this bicarbonate you would see in vomiting-induced contraction alkalosis, right? Or you could see this in proximal RTA, where the whole point is you can't hold on to your bicarbonate properly the way you should. And then when would you see euvolemia? So in this case, your urine sodium would be more than 20 milliequivalents per liter. Now, what happens here is you are just letting your sodium go, but you're retaining fluid. When would this happen? If there is syndrome of inappropriate antidiuretic hormone secretion. So ADH is going to retain free water, but you would think if ADH is retaining free water, how is there euvolemia? Shouldn't there be more volume? But what happens here is, we know stretch receptors in the heart, right? So the atria are going to release ANP, atrial natriuretic peptide. So when that is released, there's going to be natriuresis, like its name suggests. So you're letting go of sodium and some water, because you're letting go of sodium, some water will follow it in a way that your volume balance is correct, but your sodium balance is not. You're losing sodium. So there's going to be sodium in the urine, there's going to be less sodium in the serum, but your volume is going to be controlled. That is SIADH. So basically, any condition where ADH is acting up, this would happen. So when would that happen? If there's cortisol deficiency also. Cortisol usually inhibits ADH. So if there's a deficiency, ADH is going to act up. Also hypothyroidism, because in this case, your body's metabolism will slow down, cardiac output will slow down. So this will cause ADH to be released, and again, kind of the same sequence of events. Now, moving on to hypervolemia. Again, we're going to see if the urine sodium is less than 10 milliequivalents per liter or more than 20 milliequivalents per liter. Now, this is going to happen in cases like heart failure, cirrhosis, nephrotic syndrome. So, what is the common thing here? The common thing here is perceived hypovolemia, or basically the effective circulating volume is less. So when the effective circulating volume is less, the kidneys are going to think that there's less volume. Aldosterone will be released. Basically, your RAS will be activated, and then aldosterone will be released. So what will happen here? Vasoconstriction to the kidneys. You're going to be retaining sodium and water, correct? But again, along with aldosterone, you also have to remember that ADH will come into play, right? So because of perceived decrease in effective circulating volume, your ADH is going to come into play, and this is going to retain water. Your aldosterone is also going to retain sodium and water, but water is being retained by both of them, right? So what will happen? Lot of water retention compared to sodium retention. So hyponatremia with hypervolemia. Now remember, all this volume is going to be outside of the effective circulating volume. It's going to go into your interstitial space, and that's how your edema develops in such cases. Now, if the urine sodium is going to be more than 20 milliequivalents per liter, that means there is renal insufficiency. There's a lot of volume, but instead of keeping your solute in the blood to maintain an osmotic balance, your kidneys are letting go of the sodium, which means that there is some sort of renal insufficiency and the kidney is perhaps not able to reabsorb sodium as well as it should. So, this was the video on hyponatremia. I tried to make it as simple as possible. Please do let me know what you thought of it and if it helped. And yeah, I know I took quite a big break, but I hope I can be of a little help at least to you guys. So thanks a lot for watching the video, and I'll see you next time.